Yeah, no one's in yet. We're going to start. So we're waiting.
Welcome everybody. Just welcome as you're joining us in the Zoom virtual meeting room. We're just going to give it a minute or two to let people file in, and please do use the chat to introduce yourselves and let us know who you are and whereabouts you're from, and we'll get going in a minute or two. Those of you that are just joining now, welcome. Thanks very much for coming. We're just going to get started in a minute or two as people join us here. Please do introduce yourselves in the chat box. Okay, let's get started. Thank you ever so much for taking the time to join us this morning. I hope you've been having a good day so far at the conference. I know people are joining us all the time through the weekend, so if this is your first session, then particular welcome to you. If you've been with us since Thursday evening, then thank you very much for supporting Friends for Life UK 2020. My name's Chris. I'm just going to do a few introductions and then hand over to Fraser for our session here. So the session we're in is about COVID-19 and type 1 diabetes. So I hope that's what the link that you were expecting to click on. Even if it's not, then do stay here because this is a really pertinent session for now. Please, thank you all of you who are using the chat. Please continue to do that, to introduce yourselves, to comment as we're going on. Please keep it respectful. And then there's a Q&A box alongside the chat box. If you're able, please to put your questions for Fraser in there. Again, as you think of them, don't wait till the end. I'll be monitoring that and make sure that I can feed questions or group questions together to feed to Fraser. We've got plenty of time at the end for some questions. So my privilege and pleasure to introduce Fraser Gibb, who's consultant endocrinologist at the Royal Infirmary in Edinburgh. I've been there for a number of years, working particularly in adult clinics, also in transition clinics, and is taking time out this morning to talk to us about a topic which all of us have given a lot of thought to and probably a little bit of worry to over the last 6 months. The impact of coronavirus on those with type 1 diabetes. So a situation which is still evolving, which is still dominating. I mean, we'd be meeting together in person in sunny Glasgow if it wasn't for coronavirus, and we wouldn't be talking about this, we'd be talking about something else. But it is what it is, and I think it's really important at a conference and the last week in October, given what's going on in the news, that we do devote a session specifically to the virus. So very grateful, Fraser, thank you for taking the time to do this, and over to you to share your insights with us. Thank you.
Thanks very much. So hopefully you'll be able to see my slides now. And I'll maybe start off with the disclaimer here, because I'm not a virologist, I'm not a public health expert or an infectious disease specialist, I'm just an endocrinologist. And my fear that in this talk there will still be far more questions than there are solid answers, because it really is such an evolving situation. But what I'm hoping to do is spend a little bit of time on the background of COVID-19, some discussion of the effect of lockdown on diabetes, particularly type 1 diabetes, address the question, does COVID-19 cause diabetes? Talk a bit about sick day rules and the risk of DKA, and then severe COVID-19 risk factors for that. And then how there may potentially be some silver lining to this in terms of how we improve our diabetes services going forward in response to the challenges that COVID-19 has presented to us. So I say here background as if we need it, because I think we all to a certain extent have become experts in this condition over the last 6 or 7 months, because there hasn't really been anything else happening. Interestingly, I went back to my microbiology textbooks from when I was at medical school, which, as I say, was not yesterday, but back in the 1990s, coronavirus in a 600-page textbook, you'd be lucky if you got a paragraph, or in one of the textbooks, a single line in a table, and basically just saying these viruses cause common cold, which they do in the previous variants, and then almost hilariously, the coronavirus impact to the individual is almost trivial, but the impact economically and bizarrely, they focus here on the risk to time lost from academic studies as well as work. So coronaviruses have been around for a long time. They just generally haven't caused this degree of illness before, and we haven't focused very much on them for that reason. But that all changed starting from December last year, when the first set of pneumonia cases clustered in Wuhan, and then very quickly these were identified as being caused by this novel coronavirus, which by February had been named by WHO COVID-19 SARS-CoV-2. And then you just see over the coming months, as the preceding months there, as we're all aware, cases popped up all across the world outside of China, and we were particularly aware in Europe of the impact it had initially in Italy before spreading to other European countries, including our own. And as this chart here shows, over the course of the first half of this year, there's really just this rapid increase in the number of new cases per day across the world, and a really big impact, particularly in the Americas. So to look at some of the current figures, I'd updated these earlier on this week. These are the number of positive COVID-19 tests in the UK at the moment. And as you'll see, there's a really sharp inflection point around the beginning of September there, and we're in the midst of this increase in new cases at the moment. What's different from the initial peak back in April is that we're not quite at the stage where we have the same number of people being admitted to hospital. So although we're testing more and finding more cases, we still at the moment at least don't have so many people being admitted to hospital. So you'll see that peak in April, and where we are at the moment in the end of October, not quite at the same level yet. And I think a really important marker of the severity of the condition and just the comparability of where we're at the moment compared to April are the number of people occupying intensive care beds. Because whilst increased testing will find more cases, it's a fairly robust measure of how many people have severe COVID infections, how many people are requiring intensive care. And again, whilst we're seeing an increase in the number of people, it's not at the moment, at least, anywhere near that peak of over 3,000 people that we saw in April of this year. And the same can be said of the death figures as well. Thankfully, at the moment, although unfortunately there is an increase in deaths having dropped to very low levels through the summer, it's at the moment not anywhere like it was in April and May, where we were seeing up to in its peak 1,000 deaths per day. So there is cause for optimism in some respects. We know that having rapidly produced some very effective clinical studies, that dexamethasone, which is a steroid anti-inflammatory drug, is effective in those who require oxygen therapy, so those with more severe COVID-19, in saving lives and preventing ITU admissions. And you need to treat 36 such people to save one life, which is actually, for such an inexpensive therapy a very good result in a clinical trial sense. And the other medication which has some evidence is remdesivir, which is an antiviral medication, which might have a mortality benefit in hospitalized patients who require low flow oxygen, but not the high oxygen requirements or intensive care, and potentially results in a milder disease course and possibly quicker recovery. So there are a lot of other treatments which people will be aware of, and some of which have been shown to be ineffective, like hydroxychloroquine, others like convalescent plasma, and some of the fancier antibody treatments which are still undergoing clinical trials. And I think the potential light at the end of the tunnel here is a vaccine or vaccines, and there are many candidate vaccines being tested at the moment. Lots of these in the early phase studies have been shown to produce antibodies, and perhaps more importantly, T-cell responses. There's a lot of focus when you're reading newspaper articles about waning antibody responses and worries that vaccines might not produce a robust, long-lasting effect. But just as important potentially are the T-cell responses to these viral infections. And I think we really just have to wait for the final phase studies to be published, hopefully towards the end of this year, to give us an indication of how effective the vaccines are. But certainly Dr. Fauci in the United States, who heads up the infectious disease part of the NIH, National Institute for Health, is hopeful that there will be vaccines ready to go towards the end of this year or the early part of next year. And we know from preliminary animal studies as well that they do appear to have some positive impact on viral clearance. So the optimists and perhaps the realists in terms of where the science is at the moment, we'd be hoping that towards the end of this year, the early part of next year, we start to see vaccines being made available. So I'm going to move now to lockdown itself and its effect on diabetes control, particularly type 1 diabetes. This is one area where I actually can bring to bear some reasonable evidence that we were involved in collecting. And we published this study a couple of months back now. What we did was look at just under 600 adults with type 1 diabetes, and we looked at their Freestyle Libre data in early March 2020 before lockdown, and then towards the end of May 2020 in the midst of the initial lockdown phase in the UK. And what we saw in this study were improvements in time in range of glucose and reduced glucose variability. But unfortunately, although generally there was an improvement, people with greater socioeconomic deprivation were more than twice as likely as more affluent individuals to see their time in range fall significantly. So the potential benefits such as there were of lockdown and glucose control not spread evenly across all people with type 1 diabetes. And the figure here essentially just shows what I've already explained, which is that when you look at March on the one side and then May on the other, you see falls in estimated HbA1c, an increase in time in target, actually a slight increase in time below 3.9, and a fall in glucose levels greater than 10 millimoles. So we still don't know what the impact on diabetes care has been for most people, because in most clinics, and ours included, 50% of people with type 1 diabetes are using Libre, but that's not the whole picture. And we only have the data for those people who were sharing it on LibreView as well. So we can't generalize really to everyone with type 1 diabetes. We don't know anything really about whether the impact on quality of life and mental health has disproportionately affected people with type 1 diabetes more than people who don't have the condition. I think what we can say, if we're looking for an explanation for why things appear to improve, is that predictable routines, working from home, maybe making your own meals at lunchtime, perhaps make diabetes management slightly more regimented and straightforward, at least for some, but that we were not, as I've said, seeing the same benefits necessarily in people with more challenging socioeconomic circumstances. And we really do need treatments in type 1 diabetes which don't depend on shoehorning people into predictable routines for the best outcomes. That's really antithetical to everything we preach about flexible diabetes care and when we really want to see treatments as well that work just as well in every individual who has type 1 diabetes. There were perhaps worrying signs from this study in Germany, which looked at the effect of lockdown on how many cases of type 1 diabetes newly presenting were presenting as ketoacidosis, so that most severe of diabetes acute complications. And we really are driving across Europe and the world to try and reduce the proportion of children and young adults who are being diagnosed in ketoacidosis. But unfortunately, in Germany, there was an 85% increase in those presenting with ketoacidosis as a new diagnosis. And when you looked at severe ketoacidosis, that increase was almost a 50% one. So the impact that COVID had on access to healthcare and perhaps people's reluctance to go to hospital and see their GP or to have access to their GP is likely to have had quite a big effect in this regard. So next, I was going to move on to the question of whether COVID-19 itself causes diabetes, and I've only got a single slide for this because I think the evidence is extremely weak. Everyone, I'm sure, knows that there's a thought that some evidence backs up, other evidence doesn't, that viral infections are a trigger for the onset of type 1 diabetes in susceptible individuals. And there has been a research letter published from a group of diabetologists in London, which suggested an increased incidence of pediatric type 1 diabetes in the first few months of the COVID pandemic. However, that doesn't seem to have been backed up by other study data, such as the figure I'm showing here from Germany, which looks at the incidence of type 1 diabetes in a particular period, I think from March to May in the last 10 years, where there hasn't been any significant increase other than the increase we see year on year anyway in the incidence of type 1 diabetes in Europe. So I think the summary of this is far too early to say whether COVID-19 will end up being a potential contributory factor to developing type 1 diabetes, but I don't think there's any strong evidence yet to suggest that that is the case. What we do know, of course, is that for those who do have type 1 diabetes, that developing COVID-19 will have a significant impact on many. And I suppose it's worth saying initially that particularly in children and in young adults, many people will develop COVID-19 with either very few symptoms or no symptoms at all. So there will be a number of people where there's little impact even if they develop the infection. But we do know that infections are a potential precipitant of diabetic ketoacidosis. So extreme vigilance would be required in the context of concern about having developed COVID-19, including regular glucose monitoring and, where relevant, capillary ketone testing, and advice to follow sick day rules. Now, I know that Brian Kennan and Jude Kennan are doing a session later on in the conference on sick day rules, so I'm not going to dwell on this too much, and I'm also not going to be didactic about it because for different populations, whether it's pediatric or adult, and for different centres, there will be slightly different variation in terms of what sick day rules are. But of course, it centres around keeping well hydrated, making sure that glucose is checked regularly, monitoring ketones, and then reacting to ketones based on whether they're negative, slightly high, or very high. And obviously very high ketones would be a prompt to seek urgent medical attention. And there are, of course, a number of other factors, such as not being able to keep fluids down, persistent vomiting, abdominal pain, and breathlessness, where again, you would really want to seek urgent medical attention rather than wait and see what happens and try and deal with it yourself at home. So what I'll do now is move on to severe COVID-19. That would be COVID-19 which is requiring hospital admission or systemic therapy, and also what the impact of having diabetes is, because this is one of the key questions that we are asked every time we have a telephone consultation or every time we're seeing someone face-to-face in clinic at the moment, is what is my risk if I get COVID-19 of becoming very unwell, and what should I be doing to reduce that risk? And I really want to emphasize right from the outset here that the risk of death from COVID-19 for healthy young people with type 1 diabetes is extremely low. So although risks overall may be increased, and indeed that seems to be the case, the actual risk to the individual of becoming severely unwell with COVID and indeed dying from COVID is very, very low. So I'd want the tone to really largely be reassuring here. We do know from data published in England, and I'm sure many of you will be familiar with these studies. In fact, I saw already before the session started a question in the Q&A box in relation to one of these studies. But what essentially this is showing is that deaths charted here in preceding years in the red band here is the mean number of deaths in people with type 1 diabetes in England. And then the green band is deaths in 2020. And then you see as well that the blue band being deaths not related to COVID-19. So this grey box here it is showing deaths which could be attributable to COVID-19. And you'll see that the numbers here in a typical year would be maybe around about 150, and that seemed to peak at the height of the pandemic at just above 250 people. Keeping in mind, of course, that there are around 300,000 people with type 1 diabetes in England, I think, roughly speaking, at this time. I think if there's a single slide that's most important to dwell on, it's going to be this one, and I'll explain these forest plots for those of you who are not familiar with them. Essentially, when you look at these, the middle is kind of neutral, and then anything to the right hand side is an increased risk, and anything to the left hand side of the line is a decreased risk. So I'll move across a few of these risk factors in turn. And what you'll see here is that the risk is lower in women compared to men. The risk, as we've mentioned before, is very strongly related to age. So you'll see here the risk is very much lower in people under 40. And then with each increase in age bracket, that risk increases so that there is a substantially increased risk, particularly in those in the 70 years plus age brackets. There is a strong link between deprivation, and I'll spend a bit of time explaining this. So when we look in studies in the UK at deprivation, we've got quite good postcode based ways of determining this, and what we do is we put people into brackets of 5 groups, with group 1 being the most deprived and group 5 being the least deprived. And what you'll see here is that least deprived group has a lower risk of COVID related death compared to those in the most deprived bracket, where that risk is significantly increased. The same is true of the effect of race, that the white race is along the middle of this line here, but you'll see that for other ethnicities, Asian, Black, and other non-white ethnicities, the risk does seem to be greater as well. HbA1c might appear to be a wee bit complicated here in terms of the risk. It's lower in those who are between 48 and 58 millimoles per mole, or between 6.5 and 7.5% if you still work in those numbers. You might ask, well, why are those people who have got the lowest HbA1c, which is technically something that we're really meant to be striving towards, that the NICE guidelines would suggest that in type 1 diabetes we should be working towards getting below 48. Well, I think the way to explain this and to reassure people is that in most studies which look at the link between HbA1c and mortality, you quite often see a slight increased risk of mortality in HbA1c less than 48. Now, that's not likely to be in people who are managing their diabetes very tightly. It tends to be a marker of HbA1c falling in people who are ill for other reasons, and you quite often see towards the end of life in people with both type 1 and type 2 diabetes that HbA1c falls for other reasons. So I wouldn't be alarmed if you're someone who's working really hard to get your HbA1c down below 48, that this statistic here is of any concern. I think it simply reflects something we see in lots of other studies, and clearly those with the very highest HbA1c levels were at higher risk of mortality related to COVID-19. Kidney function was another factor. So people with abnormal kidney function, depending on the degree of that, it increased stepwise. So those with the most severe kidney disease, and when you're down at the kind of level right at the bottom here, these are people who are effectively in stage renal failure requiring dialysis or transplant. So people with normal renal function, relatively low risk there. And again, the weight picture suggests that people in the bracket of a BMI that's just above normal and into the overweight appear to have the lowest risk, whereas those who were obese had the highest. You might again wonder why people who've got lower weight are apparently at higher risk, and I think it's a similar picture to the HbA1c one, which is people who are losing weight for other reasons often have other illnesses to account for that, and that's probably why you're seeing a signal there towards an increased risk in people with lower weight. There are similar figures coming out of Scotland, and these are data that are just about to be published by the Scottish Diabetes Research Network. And what it shows is the dotted lines are people who do not have diabetes. The solid lines are people who do, either male or female, depending on the colour coding. And the thing to focus on here across these age brackets is that the risk of severe or fatal COVID is exceptionally low, not only in the 0 to 39 age bracket, but also really effectively in the 40 to 49 and the 50 to 59 age bracket overall. So although the risk is higher than in people who do not have diabetes, the overall risk remains relatively low. And I just wanted again to emphasize the impact of socioeconomic deprivation, which appears to be holding true both in type 1 and type 2 diabetes in Scotland, that this is a risk factor for either severe COVID-19 or death related to COVID-19. And that's something we really do need to address. Although risk calculators are difficult to think because they use data from an entire population to try and give you some indication of the risk to an individual, it's probably, with all the caveats and all the reservations you would have about such things, this qcovid.org risk calculator from the University of Oxford is probably one of the better ones that are available at the moment. And what I've shown here, the sorts of things that you would input into this to be given information on COVID risk. And that includes age, gender, ethnicity, weight, postcode, which takes into account socioeconomic deprivation, and then obviously the diabetes part here, but then other conditions such as kidney disease, learning disability, cancer treatments, lung, neurological, heart and circulation problems, and other conditions. So completing that calculator then provides a rough estimate of risk. And the reason I've provided this table here is really just to show again that if you take a 20-year-old man, for example, and with the top one here is who does not have type 1 diabetes, the one below is who does have type 1 diabetes, normal weight, and then plug that into the calculator, you'll see that this was based on the risk of catching and dying catching COVID-19 and dying from it over the 90-day period, based on data from the peak of the pandemic, the first peak of the pandemic. So that 90-day risk for someone who doesn't have diabetes would be about 1 in a million. For someone who does have diabetes, it's 1 in 166,000. And so overall, it's a 6 times increased risk, but the number itself is still extremely low, nearly 1 in 200,000. And I've done the same in this table, just plugging in data for imaginary individuals who are normal weight, and you see the same thing in females, although the risk's 5 times higher in that 20-year-old, the overall risk is 1 in 100,000. And I've done that in this table all the way up to the age of 40, and you'll see even in a 40-year-old man with type 1 diabetes, that risk of death is calculated at about 1 in 11,000 compared to 1 in 66,000 in someone who doesn't have diabetes. So a big multiplier, 6 times the risk, but overall to the individual, the risk of COVID-associated death and indeed COVID-associated hospitalisation remains extremely low, even in the context of this being at the peak of the pandemic. So the risk is undoubtedly higher, but the actual risk is low. And I think the thing to focus on are modifiable risk factors. There are certain things that we have no control over, but there are things that we do. And one of those is potentially high HbA1c. And we know, unfortunately, that 70% of adults with type 1 diabetes in the UK have an HbA1c that's over the 58 millimoles per mole target. And unfortunately, only a minority of adults with type 1 diabetes have access to structured education, use insulin pumps, and use either Freestyle Libre or CGM. So these are things that we genuinely can address. And with that, I'll move on briefly to just reimagining the diabetes services as we emerge from the pandemic. And I'm showing here results from a study that we're just about to publish in Scotland, showing the massive impact of insulin pumps on HbA1c, and in particular, looking at people who start with a very high HbA1c. So looking at those with an HbA1c over 84 to begin with, you see the baseline goes along here. And then when you start a pump, you really have these dramatic reductions in HbA1c. But not only that, you have dramatic reductions in DKA, and you have dramatic reductions in people being admitted to hospital for severe hypoglycemia. So point number one would be, let's make sure everybody who'd benefit from an insulin pump gets one. The second study that I present is similar figures, but just looking at flash monitoring, which shows that across pretty much every age bracket, flash monitoring is associated with substantial reductions in HbA1c. And again, those with the highest starting HbA1c, as you see on the right-hand side, are those who stand to gain most from flash monitoring. They have the biggest reduction in HbA1c. Not only that, but similar to insulin pumps, what we were able to show is across pretty much all age brackets, and both in men and women, significant reductions in people being admitted to hospital for DKA. So if you're thinking about COVID risks and risks of DKA and the risks of high HbA1c, we certainly want people to be on the best possible diabetes treatments to give them the best chance of avoiding these types of complications. I think in terms of things we can do to manage our diabetes services better, we're learning how to be more flexible, doing more remote consultations more frequently potentially in people who need it most, and then offering face-to-face consultations when required, doing more remote data sharing to help improve glucose control, and more targeted services, as I say, so seeing people regularly who desperately need the help there and then, and maybe just being a wee bit more pragmatic, and importantly focusing on expanding technology provision. And I'm going to finish off just with a simple summary again, which focuses on inequality, because what we see, and these are data from my own clinic that we're just about to publish, is that when it comes to socioeconomic deprivation, that the likelihood of having a very high HbA1c is highest in those who are most disadvantaged. The likelihood of having an on-target HbA1c is much higher in those who are least disadvantaged socioeconomically. The likelihood of being on a pump, of using flash monitoring, or having attended the Daphne course is much higher in those who have least socioeconomic disadvantage. So whether it comes to COVID or whether it comes to managing type 1 diabetes, we need to start thinking about treatments and services that cut across all aspects, whether that's age, whether it's gender, whether it's socioeconomic. And with that, I'll finish with the familiar hands, face and space slide and open things up to questions.
Hey, thanks very much, Fraser. You covered a lot of ground in a short period of time. Questions have been coming in the Q&A. I know you've seen some of them. As I've looked at them, I think they kind of fall into two areas. There's some questions about risk, about people's level of risk of contracting the virus and of hospitalization or death with the virus. And then there's questions about ongoing management of type 1 in a world in which there is coronavirus. So maybe let's start with some risk ones. Any data? I mean, we've seen Partha's data on risk of death. Is there any data out there on risk of hospitalization or for people with type 1?
Yeah, the risk of hospitalization in terms of the risk factors kind of follows fairly closely to what the risk of death is. So I think anyone who's at higher risk of death is also at a higher risk of hospitalization.
Okay. And someone asking whether there's a link between length of time with type 1, period since diagnosis. So are people that have had type 1 for longer more at risk, or is that just correlated with age, I guess?
I think it's very difficult because it's hard to disentangle the effects of age on the risk of this. And also, you're much more likely to have diabetes complications, including, for example, kidney dysfunction or underlying cardiovascular disease, if you're older and have type 1 diabetes than clearly if you've had it for a shorter period of time. So I think it's hard to know absolutely whether just duration per se is a risk factor. And I imagine somebody who has had an HbA1c of around 53 for almost the duration of their diabetes, their risk is probably going to be lower, even if they've had diabetes for 30 years, than someone who's had diabetes for 10 years and has an HbA1c of 75. But that's, I really am only extrapolating there.
Okay. A few questions on management. A couple of people asking about vitamin D. So I know there's been some things in the press more recently about vitamin D deficiency, and there were two specific questions. One about whether people ought to be on vitamin D supplements, and second about anything more general about links to vitamin D deficiency and autoimmune conditions.
Yeah, so I've always tried, ever since I was a trainee in endocrinology, I've always had this enthusiasm for vitamin D, which has unfortunately never really been borne out by any subsequent evidence. So it seems really compelling, and there's lots of good observational evidence that vitamin D is linked to certain health outcomes. But then when you do randomized controlled trials where you replace vitamin D, you very rarely see any major benefits. Now, there are some meta-analyses that suggest that vitamin D reduces the duration and the severity of upper respiratory tract infections, for example. And my broad advice anyway is, because vitamin D, we know it doesn't really do any harm, we know it has some potential benefits, I tend to take a vitamin D supplement myself, and certainly for at least 6 of the winter months, because there's at least 6 months, if not more, in the UK where the sun isn't sufficient to produce vitamin D for most people. I would tend to encourage most people to take vitamin D. I think in terms of any robust evidence that it reduces COVID severity or influences outcomes, it's lacking. And there's a school of thought that vitamin D is a biomarker for and increased fitness in general. And there's even some biological evidence potentially that there affects other systems which sunlight on the skin improves that are not actually vitamin D related. So I think by all means follow the advice. Generally say to people it's sensible to take vitamin D supplements over the counter, but I don't expect it necessarily to have a big impact.
Okay, thank you. Someone early on had a really very practical question. So in a position where someone with type 1 is doesn't themselves have symptoms or hasn't tested, but has been asked to self-isolate by the track and trace people or whomever, any practical suggestions for people effectively managing their type 1 in isolation?
I mean, it's so hard, isn't it? Because it really depends in what way that impacts on an individual's routine. And for people where there's then a substantial reduction in their physical activity, they're probably going to start to find that their environment changes dramatically. But I'm not sure there is really a one-size-fits-all response to that. I think people really just have to be extremely vigilant with their glucose monitoring, and hopefully these days most people have access to some form of continuous monitoring, whether it's flash or real-time CGM to help with that. But yeah, I think it's difficult to give a single answer.
Okay, fair enough. Linked to that that CGM point, some people saying that as we move to remote or digital clinics, certainly at the moment, and I presume that we're never going to go back entirely to the old way of doing things, does that increase the case for CGM? Because the remote upload of data, but also people not getting their HbA1c tests at the moment, at least they could get an approximate value through CGM, and should health boards and clinical commissioning groups actually be altering their advice on CGM availability in the light of what's going on at the moment?
Yeah, well, you'll maybe have noticed in my talk that I've basically tried to twist the last part of my talk away from COVID and just towards an appeal to widening access to technology, and it's because they are linked. But fundamentally, we know now that with systems like Basal IQ, with the 780G, with people who are doing DIY closed loop, we have systems now which, in those who are able to take advantage of them, can effectively result in almost everyone who uses them and is capable of using them getting to targets in terms of time and range. So why on earth should we be arguing around the edges about who gets access to flash monitoring or who gets access to pumps? We should really be knocking the doors down in all of these CCGs and all of the health board areas to make sure that we get rapid uptake of closed loop systems, hybrid closed loop systems, as quick as possible for as many people as possible, and ultimately anyone who wants one, basically. We wouldn't be scrambling about begging for money if we were talking about funding for cancer therapies or even some cardiology treatments. And we shouldn't be in diabetes either. We've got the opportunity within the next 2 or 3 years with the technological advances to revolutionize the lives of people with type 1 diabetes. And when you look at something like disparity in outcome when it comes to COVID, that's unacceptable. That's just really putting another focus on it. But the same is true if you look at cardiovascular disease or premature mortality. Why should we, when the treatments are there, be having to beg and find money from all different sorts of routes, when we should just be getting these treatments? So it's an impassioned plea, I think, that there's a lot of patient power out there, and that's what's going to push the funding.
Great, thank you. Two last questions, if we can squeeze two in, two quite different questions. So the first one relates to your thoughts about long COVID for people with type 1. So I know that this is emerging and an issue. Anything you've seen in some of the early investigations about whether long COVID is more of a risk for people with type 1, whether people with type 1 and long COVID is going to be a problem?
No, I honestly don't know a huge amount about this, and I think probably nobody does, because I don't think there's a lot of good public evidence, because it's too early, just by the nature of it being long COVID, and nobody in this country had COVID before March. So I don't know. I think that there's a real focus on this, but of course there have been people for years who've suffered from similar things in terms of post-viral syndromes, and we'd expect the same to be true here. But whether people with diabetes are disproportionately affected, I couldn't really say with any certainty. Okay, thank you. And then the last question is one that I think a lot of us parents will have thought about over particularly with the returns to school in August in Scotland and September in the UK, and one, I guess, about whether government guidelines go far enough, or whether we ought to be doing more as individuals. So obviously different people's circumstances are different, but I get a lot of parents are thinking, can I trust the government guidelines? Can I trust the systems that schools are setting up? Or should I go further as an individual and take more precautions? I understand you probably need to be careful about what you say in that regard, but is there any kind of roadmap you could give us as parents in terms of the way to think about that? Yeah, I think you're right. It's really hard for me, and I don't have kids with type 1 diabetes, but I do have a couple of kids of primary and high school age, and my feeling, and I say this almost more as a layperson than as a specialist, so I think don't take this as necessarily specialist advice, but I think the risks overall to children are so low that I think the systems that are in place, in my view, are appropriate. And the harm, I think, potentially of denying education and socialising to kids appears to be much greater than the potential health risks of contracting COVID. There's a lot to criticise, I think, in the government's response, both north and south of the border, but my own view on the school side of things is I think it's probably sensible.
Great. Okay. Thank you. We've run out of time. We've covered a lot of ground. Fraser, I appreciate that you've covered a lot of ground, but you've also done it in, I think, at least to my ears, in a really reassuring way as well. So you've given us data, you've given us your insight, but also I think you've given everybody in the virtual room some reassurance about there. Clearly a lot more for us to learn, you know, whether it be about vitamin D or long COVID or what's going to happen in a second wave. But I really appreciate you coming at this point on Saturday morning and sharing your expertise and professional perspective with us. Thank you everybody who has joined in the session. Could I ask that if you have time sometime between 12:30 and 2, that you drop by the virtual sponsors room, in particular Insulet have something where they're sharing things about their Omnipod technology. These conferences wouldn't happen without the sponsors, Beta Bionics, Insulet, Abbott and LifeScan. So please do support them if you can. Fraser, thanks ever so much for your time and your insights and sparing time with us this morning. Thank you.
Pleasure. Thank you.